Welcome to AETCM, the emergency medicine channel. Shall we start, sir?
Please.
A 51-year-old female came to ER with complaints of heavy menstrual bleeding since last 20 days. On initial 10-second assessment, airway was patent, no pooling of secretions, speaking in full sentences. Coming to breathing, respiratory rate was 18 breaths per minute. SpO2 was 98% on room air. On circulation, heart rate was 110 beats per minute, BP 110 by 80. Capillary refill time was less than 3 seconds. Peripheral pulses were present. IV access was secured. Disability GCS E4, V5, M6 exposure. Patient was left with died. Adjuvants to primary survey, CBC, we took a CBC CRP, total count was 7.6, HB was only 5.5, hematocrit 16.3, platelet was 2,86,000, CRP was only 0.3. Coming to VBG, there was no acidosis or alkalosis, sodium was 135, potassium 4, lactate was 1. Arrangement was made immediately for 4-pint PRBC. Coming to sample history, a 51-year-old female came to ER with complaints of heavy vaginal bleeding for last 20 days associated with passage of large clots. Patient is also having fatigue, dizziness and breathlessness on exertion since last 3 to 4 days. Patient has changed more than 10 pads every day. No history of bleeding in between periods or post-coital bleeding, so we have ruled out polyps. No history of dysmenorrhea, so we have ruled out adenomyosis. No history of weight loss or foul-smelling discharge. The history was asked to rule out any malignancy or infection. No history of use of any anticoagulants. Coming to menstrual history, the age of menarche was 13. She was having regular cycles till now. Her last LMP was 20 days back. Coming to obstetric history, gravida 2, para 2, all were vaginal deliveries. Contraceptive use, she had underwent tubal ligation 10 years back. No history of any drug allergies, not on any medications, no comorbidities. Coming to examination, CVS S1, S2 was heard, no murmurs. Coming to CNS, no focal neural deficits. RS, air entry was bilateral and equal, no Krebs waves.
So although the patient, you say that she was breathless, there was no sign of failure at all?
Failure.
All right.
On per vaginal examination, the patient had active bleeding with clot seen. So initially, since her heart rate was elevated but her BP was maintaining, and we had arranged for 4-pint transfusion, and initially we started on IV fluid resuscitation, and then we gave injection tranexamic acid 1 gram IV.
All right.
So we have also, meanwhile we had done beta HCG levels to rule out pregnancy. Then we did a bedside ultrasound which showed a bulky uterus, which was bulky according to her age, with multiple fibroids. There was a lateral wall subserosal fibroid measuring 3.5 into 3.2 centimeter. Right lateral wall subseroidal fibroid measuring 3 into 2.7 centimeter. Anterior wall subserosal fibroid 1.7 into 1.1 centimeter. Thickened endometrium measuring 20 mm. And in her HB, since her HB was 5.5, which was less than 7, we had initiated on 1-pint PRBC. At the meanwhile, we had called for gynae consultation also.
All right.
Then the patient was shifted for observation and for further evaluation. Later, she had underwent dilatation and curettage.
All right. So, to sum it up, we had a 51-year-old female patient who's still having her periods going on, and she's been complaining of heavy menstrual bleeding. So, but there was a severe HB drop.
Yes, sir. Last recorded HB, according to her, we didn't have any documents. It was 13.1.
13.1. All right. Okay. And after that, the HB has dropped to 5. So it's been a chronic bleed, but
there was no signs of
heart failure.
Yeah.
All right. Now, when we come to the topic of abnormal uterine bleeding, how do you define abnormal uterine bleeding?
Bleeding that is abnormal in regularity, volume, frequency or duration. Normal bleeding duration is 4.5 to 8 days within an interval of 24 to 38 days. And normal loss of blood is 20 to max up to 80 ml. More than 80 ml is considered as abnormal.
Abnormal. Right. So when we talk about this concept of uterine bleeding, we should also know about how the hypothalamo, pituitary, ovarian axis functions. I'm talking about how the menstrual cycle and the
Cycles.
hormones work, right? So could you brief about how that cycle works and how the hormones are?
Regarding the
So
luteal phase and
exactly. So when we talk about it, you have the ovulatory cycle and the uterine or the
uterine
endometrial cycle, right? So basically because we are looking about the pathologies in the uterus itself, we'll just focus on it more. So the the ovarian cycle basically would have the cycle of menstruation followed by follicular phase, and then there is the secretory phase. The luteal phase, sorry. And in the endometrial cycle, there is the menstrual phase first, follicular, followed by the follicular phase, and then there is the secretory phase. So we should also know about the hormones here. Initially, there is the gonadotropin releasing hormones, which is secreted by the hypothalamus, which stimulates the anterior pituitary to release the FSH and LH. And then you have
LH peaks and then luteal.
And then you have the ovarian hormones, which is estrogen, and then you have progesterone, which is secreted by the corpus luteum. So in the uterine cycle, the initial cycle that we talked about is the menstrual cycle that is happening, which is from 1 to 5 days, right? In that phase, what happens? Progesterone, estrogen levels are very low, which stimulates the gonadotropin releasing hormone from the hypothalamus, which would again stimulate FSH and LH, which leads to recruitment of the follicles. This is what happens in that phase. In the second phase, which is the follicular phase, what happens?
The FSH is released and the follicles start growing.
Yes. And then the growth happens. The dominant follicles start secreting estrogen, right? And estrogen, towards the mid-cycle, it peaks. Once it peaks, what happens is there is an LH surge. LH surge on the 14th day would ensure that the meiosis of the oocyte is over and the ovulation happens, right? Ovulation happens, and after that, if at all, the follicular capsule would involute to become the corpus luteum, which would secrete progesterone, which would lead to endometrial changes, which makes endometrium more receptible for pregnancy, makes it more secretory, secretory in such a way that it can supply the nutrients to the embryo, and the cervical mucus becomes thick, which would be thin when the estrogen is there, because the sperm should penetrate better. And ultimately, this is what happens in the endometrial phase, right? So this is a phase, and because we need to know this better, because we are going to meddle with mostly the hormones and alternating the cycles or the pathways to stop the bleeding, right? So this is the normal cycle that we know about. Now, moving on, we should know about when such a patient comes, we should know about what the history and the physical examination we should be eliciting. So what all histories do we normally focus on?
First, we'll have to ask about the reproductive history, age of menarche, menstrual history, date of LMP, her normal pattern of normal cycles, presence of any dysmenorrhea. Coming to sexual history, current sexual activity, any contraception use of any barrier protection. We'll have to ask her gravida and para, history of ectopic pregnancy, history of any previous pelvic inflammatory diseases. Coming to trauma, postcoital pregnancy, possibility of any retained products, or history of any previous abortions or any DIC in the last 1 week or last 1 month. Any medications like anticoagulants, NSAIDs and OCPs has to be asked. Any past medical history like signs and symptoms of coagulation. If we are suspecting a coagulopathies, we'll have to ask patient is having any ecchymosis, nosebleed or petechiae. And history of PCOS and hypothyroidism has to be asked.
Yes, any history of trauma as well.
Has to be asked.
And also any history of previous sexual contact. Right.
Retained products of foreign body.
Correct, foreign body. Now, when a patient with heavy bleeding present for the first time, you should always rule about coagulopathies as well, because more than 20% of the patients who present for the first time with heavy menstrual bleeding can have coagulopathic disorders. So what are some of the features that would suggest that, okay, this patient might have coagulopathies, and we should screen for them?
If the patient is having previous histories of any gum bleeding, petechiae or epistaxis,
EC bruising.
EC bruising will
And
have to.
extreme severe bleeding,
Bleeding
on
from
dental
last
or
periods,
surgical
yeah.
procedures. All this, points towards one of the coagulopathic disorders. The von Willebrand disease being the most common amongst these. Yes. Now, once you've taken up the history part of it, we should move on to the possible causes in each age group, so that you can know the spectrum and where to and what to investigate. So if you divide it into adolescent and the reproductive age group, perimenopausal and postmenopausal, what are the most common causes?
First of all, the classification, we have a mnemonic, sir, PALM-COEIN. It includes polyp, adenomyosis, leiomyoma.
Those are the causes. But I want the spectrum first, and then let's go to the.
In adolescents, the most common is anovulation.
Anovulation, right.
PCOS, like most probably PCOS, sir. Pregnancy, exogenous
anovulation in the adolescent group.
Adolescent group.
Anovulation in the reproductive age group is mostly due to PCOS. But in the adolescent group, it's because of
the hypothalamus-pituitary is not
the immaturity of the. What happens is there is constant estrogen stimulation, which leads to endometrial proliferation, and but there is no progesterone activity there. What happens? The endometrium keeps proliferating, and the spiral arterioles try perfusing the endometrial stroma for a long time, but then once it's become highly proliferated, you cannot, and then sloughing happens. So they present with anovulation for a long time without bleeding for a long time, but eventually they bleed a lot towards the end. So that is something that you should keep in mind. All right.
Okay, then in adolescents, we'll have to rule out pregnancy.
Pregnancy, of course. Yes.
Any exogenous hormones, any tumor secreting exogenous hormones, coagulopathy.
Exogenous hormones are normally iatrogenic. Because these maturity is there, we normally tend to normalize it. So yeah, next.
Then pelvic infections.
Pelvic infections, very good.
In reproductive age, the most common is pregnancy, then anovulation, OCPs, uterine leiomyoma, cervical and endometrial polyps.
Polyps, okay.
Coming to perimenopausal, it is anovulation, uterine leiomyoma, cervical and endometrial polyps, and thyroid dysfunctions.
Thyroid dysfunctions. Which thyroid dysfunction would?
Hypothyroidism. Sometimes hyperthyroidism also. Postmenopausal group, most common is atrophic vaginitis.
Atrophic.
Then endometrial lesions, it can be malignancy also. Other tumors like vulvar, vaginal and cervical tumors has to be ruled out in postmenopausal.
Right. Now let's go into the the mnemonic that you were talking about. Yes.
PALM-COEIN, includes polyp, adenomyosis, leiomyoma, malignancy and hyperplasia.
So which one is structural? These are structural causes.
Structural causes,
right,
yeah.
Right.
Then COEIN includes coagulopathy, endometrial causes, iatrogenic, and N is not otherwise specified.
Yes. So when it comes to polyp, right, how do they normally present?
Usually they will have postcoital bleeding and intermenstrual bleeding also.
Will be there. So just
most
give me some.
Is seen, usually it is commonly seen in age more than 35 years.
Understood. So adenomyosis, what is adenomyosis?
It's the presence of endometrial gland within the myometrium. So it starts studying.
So what happens, how do they present, these patients?
They present with severe dysmenorrhea.
Dysmenorrhea, severe pain, right?
Yeah.
All right, okay. Next.
Coming to leiomyoma, this is the most common cause which we see in day-to-day basis.
Yes.
Signs and symptoms of fibroids vary depending on the location of the fibroids and depending on if there is any degeneration, all of that.
Exactly. So the most important thing when it comes to fibroid is the complications that you should look for.
And we'll have to always rule out torsion because that patient comes with torsion and degeneration. Red degeneration.
How do they present? Degeneration, how do they present?
Severe pain and...
severe pain, right. Severe pain. They might have an elevated CBC, the WBCs, and then the patient can have fever as well. When it comes to torsion, that is severe pain. Yeah, right. All right.
Red degeneration is most commonly seen in pregnancy because the blood supply...
Correct.
It starts growing, but the supply will be reduced.
Right.
Then Other causes involves malignancy and hyperplasia. Then coagulopathies. Structure.
Yeah, in structural causes, the last one is malignancies and hyperplasias, right? So if a patient, say a postmenopausal, because malignancy, should be ruled out until and otherwise a postmenopausal or a perimenopausal patient starts bleeding, mostly postmenopausal. So in these patients, does the amount of bleed correlate to the disease?
No, sir.
No, it doesn't. That is something that we should always keep in mind. Even if the patient is bleeding very less, it doesn't mean that the disease severity might be low. You should be investigating the patient with much rigor and thoroughly, right? So we finished the structural causes. Next, non-structural causes. What are they?
Coagulopathies, most common being von Willebrand disease. But in emergency, we don't have to rule it out as an emergency. Only after we have ruled out all other structural causes, and if there is an indication, then we can go ahead with the investigations.
All right. Okay.
And then endometrial causes. If on initial screening, if we find any elevated endometrial thickness, then we'll have to initially we'll do a pap smear, then curettage, endometrial curettage.
All right. So endometrial causes is again, we should rule out every other cause to call it it's purely from the endometrium, something is wrong with the endometrium, and then this happens, right? Then there is something ovulation dysfunction is also there in between. After coagulopathy, it's ovulation dysfunction. So again, ovulation dysfunction and ovulatory cycles can be maturity or PCOS related, right? And then can be iatrogenic as well, because of the if we start OCPs in between. But then we have a separate iatrogenic section for it. So coagulopathy, ovulation dysfunction, and then you have endometrial causes. After that, it is
not otherwise specified.
Not otherwise.
Iatrogenic
and not otherwise specified. All right. So we finished the causes of it. Now, what are the investigations that we normally do for these patients?
Investigations, first we'll have to, whatever the age group being, first we'll have to obtain a UPT to rule out pregnancy. Then only consider coagulation profile if indicated, and if you have ruled out all other causes. Then USG to rule out adrenal. USG is the first investigation of choice. Ultrasound abdomen or pervaginal ultrasound can be done to rule out. Transvaginal ultrasound can be done to rule out adnexal or uterine mass. It can also determine the uterine size, presence of leiomyoma, ovarian cyst, hydrosalpinx, pelvic adhesions, tubo-ovarian abscess, endometriosis, and tumors.
Right.
If there is massive...
Now let's move on to the treatment. Yes.
If there is massive uterine bleeding, first we'll have to give the patient fluid and blood resuscitation, identify and treat. If we are suspecting a coagulopathy, we'll have to identify and treat the coagulopathy.
So one thing when it comes to any bleeding, be it trauma or anything, is that
coagulation profile has to be
15% of the blood is lost, only then the symptoms starts appearing. So almost more than 750 ml should be lost for the symptoms to appear. That should be behind your head once you start treating the patient.
So here, since we had a tachycardia, we are suspecting a kind of type 2 hypovolemic tachycardia, but BP was normal.
Okay.
Then it's very important to exclude pregnancy or any previous DNC or previous abortions to rule out retained products of pregnancy. Then the drug tranexamic acid that prevents fibrin degradation can be given 1 to 1.3 gram IV. Then we can continue with 3 times a day, 500 mg 3 times a day. But it is contraindicated if the patient is having a venous thromboembolism, vascular disease, malignancy. Do not give tranexam.
Okay.
Then we can also give conjugated equine estrogen.
Okay.
25 milligrams every 4 to 6 hours can be given.
Until the bleeding stops. So the contraindications for tranexamic acid, the same
thing.
Would apply for estrogen
also.
All right.
And if patient is hemodynamically stable and we are suspecting a fibroids, leiomyomas, then we can give combined OCPs or NSAIDs. In combined OCPs, we give monophasic combined OCPs less than 35 micrograms of ethinyl estradiol 3 times a day for 7 days. Usually the bleeding stops by 3 days. But it has many contraindications. If the patient is a smoker for more than 35 years, hypertension, pregnancy, venous thromboembolism, breast cancer, diabetes, thromboembolic disorder, heart disease, diabetes, all of these patients, we cannot give estrogen. combined pills. Then methyl medoxyprogesterone acetate also can be given 20 mg per oral 3 times a day for 7 days. Here also usually the bleeding stops by 3 days. Contraindication being liver disease, breast cancer and ovarian cancer. Then NSAIDs like naproxen or mefenamic acid also can give. This can be given 3 times a day for 4 to 5 days. Mechanism of action being it will reduce the progesterone inflammatory reaction, so pain can be reduced in case of
It
this.
promotes the correct cyclooxygenase, arachidonic acid pathway. Yes, and what happens is PF2 alpha PGE2 ratio is altered, which would enhance vasoconstriction, so would prevent the bleeding. Right. Anything else that you want to add?